So we are the last panel between you and the end of the day, and we recognize that. So we are going to try to be brief, but then also have as much discussion as possible. I'm CATALINA GONZALEZ MARQUES. I'm the Director of Emergency Health Systems at Harvard Humanitarian Initiative. I have many of my colleagues with me, as well as Alicia, a colleague from Med Global. And specifically, we are the humanitarian hub at Harvard, and we are academic, but also our team is somewhat programmatic, and we've had experience the last 3 years in Ukraine. We're going to talk a little bit about that, and then also give our colleagues some time to talk about their work, and then open it up for questions. So very briefly, this one's working great. We were approached by International Medical Corps, a large humanitarian organization that is US-based, and they let us know in 2022 that they had done a needs assessment in Ukraine. And they said, and they had been working in the country for many years. Their base was actually originally in Mariupol. And they said, what we've identified amongst our connections and our stakeholders is that there's a lot of gaps and needs in trauma patient assessment and treatment, in mass casualty and surge preparedness amongst hospitals in Ukraine, and then also chemical, biological, radiological, nuclear, and explosive training and preparedness. I cannot say that every time, so we call it CBRN. Because it's quite a mouthful. And so they came to us and we said, okay, what can we do with the needs assessment that you have, with the information that you've given us? And we proposed these 7 different course lines together with colleagues from the WHO. We worked with the American College of Surgeons as well for ATLS, because not only did we want access to the course, but we wanted to be able to train trainers and then promulgate the course, which is still in process, but we've gotten there. We also had Trauma Nursing Fundamentals, a pre-hospital program, specifically pediatric, because children are also, we're seeing pediatric traumatic injuries that we hadn't seen before. Stop the Bleed for lay people, because again, we were trying to catch the entire trauma spectrum. And then mass casualty management and our CBRN courses. And this was our vision. So we've been asked, and we're gonna work with many partners to do this robust trauma care and response training, targeting the entire trauma perspective, so from laypersons all the way to healthcare systems. And now humanitarian, we often do things quickly and we leave and we don't look for long-term impact, right? We're typically putting a Band-Aid on. But we saw an opportunity to make this scalable, sustainable, and adaptable. And I'll talk about how this came together with our partners, because our courses were exclusively taught in Ukrainian. We had a train of the trainers model, and we rapidly made sure that all the trainers were the ones training. So basically, we wanted to work ourselves out of a job as fast as possible, and then to find ways to continue to support, but not being the main people. And this is kind of what it ended up looking like, but I want to spend one moment talking about how many partners this required to actually make this happen. Specifically GMKA, so I know Nelia's here and her team is here. They were the ones who helped us translate the materials, achieve permissions for translating materials. And then also we had Boston Children's provide pediatric expertise. I know this is now a relic, but this project was funded by USAID and International Medical Corps as well. And this is basically what it looked like. The X's here are the reach, so where we went. We went as far east and south as we could. Wherever International Medical Corps identified a need, we had these 7 course streams. We taught over 300 courses. We trained over 7,000 participants, and I actually think the number is closer to 8,000. We did 760 training of the trainers that we supervised. We did the monitoring and evaluation for, and we did the support for them. And that produced 158 Ukrainian course instructors, and 62 of those, we did additional training with them to make them master trainers in these courses. And we had partnerships with multiple academic institutions as well. And I'll talk a little bit about what, we kept trying to think, how can we scale this? How can we make this more? And we were able to create asynchronous videos that kind of also taught this content. And we reached 7.4 million views across 500 cities in Ukraine. And this is kind of just more of where our team went. And again, these were not only our intervention regions, but a little bit of what this looked like. So this is our Save a Life Ukraine trauma training care courses. They are free, open access online on YouTube. And then these are our many, many courses, although I do believe our CBRN courses were probably the most popular. And then, I heard this in the prior panel, you can do all these things, and we can do these things kind of in the intermediate, but then we need downstream things. We need healthcare impacts. And so we were approached by some Ministry of Health and Ukrainian stakeholders, and they said, well, the thing is the emergency care units aren't set up to kind of meet these patients. So how do we kind of operationalize this? How do we make this work? And so basically we came together again, this time with International Medical Corps, and it sounds very boring, but we met with Ukrainian partners and we helped them create standard operating procedures for how to deal with trauma, with CBRN preparedness in their hospitals. And then we actually drilled this. We drilled this multiple times with them. And we had simulations, and we had tabletop activities so that they understood the operating procedures and how to move about in their own emergency unit, how to respond to things, how to follow the protocols that they helped guide and create. And then these are kind of our large-scale training drills. And, it's important to be honest with your friends. There's been quite a changed humanitarian landscape. These programs did lose all of their funding in the loss of USAID for the most part. We stopped at a good point, though, where we already had our Ukrainian instructors doing everything, but we then were able to partner with Project ECHO, GMK again, to create a virtual community of practice. For those who aren't familiar with Project ECHO's work, they basically started kind of as virtual consultations, specifically around HIV, and they've now expanded, and they create kind of virtual communities of practice where trauma providers can come together in our case and kind of share cases together, share trainings. If they have a question about a technique they'd like to learn, we pair them with an expert so then they can continue learning. And then I want to give a second to our colleague.
Oh my gosh, yeah. Could sit here and listen to you guys too.
No, you don't have to.
Yeah, ours was a little bit more organic, just because I'm an ER nurse by trade. Went over with Med Global as a volunteer in 22 to do an assessment of how we could assist nurses, basically. And to our surprise, what we didn't see coming was that they ended up wanting, all of the hospital wanted BLS, ACLS, and PALS training. So we started working with AHA International so that we could start doing those trainings over there, certifying those trainings, and then now working with Ukraine and Ministry of Health to start doing an American Heart Association within Ukraine. They generally have been doing it the EU standards, and so now they're going to have an option for both. And so that's the goal of eventually being able to hand it off to everybody else. So that's been pretty much our big focus, but I know the other piece too is just really trying to get in with the nurses. Because I'm ER, I'm very basic. Everybody should be doing compressions. Like if you don't have a heartbeat, what are we doing? So like being able to get those basic skills, you're ER, that's why, yep. I don't need a hemoglobin. If they don't have blood, they're not good, like that's it. So getting those basics in, I think is really huge for me. And I know Med Global has really been trying to push even more getting that kind of basic foundational training. It was brought up in the previous panel as well, that basic foundational training so that as system rise to the occasion, the nurses already have that basic foundational training to then build upon. So like with ATLS, there is a whole program that goes right along with it where the nurses can go. They branch off for different sections and parts, but it's the same textbook. And so how do we get that foundational training in there so that way, once the system rises to the occasion, they'll be able to meet the need. So, yeah.
Thanks. And so I definitely I'll start off with a question, but then obviously I want to hear, there's probably so much profound expertise in this room as well. I want to hear a little bit from, our panelists, kind of talk to us a little bit about that process of going to these organizations that own this content that you hear is like desired, and how did you go about getting those certifications, and how did you go about training and then providing those courses?
Me? Oh, sorry.
Anyone?
Go ahead.
Tim, maybe you could speak to the CBRN content because
Sure.
There's really a lack of standards there, and we created actually a lot ourselves.
Yeah, first of all, we didn't just go and teach and say, this is how it's done. Our Ukrainian partners were incredible. and are incredible and resilient. They were eager learners despite frequent bombings and bomb shelter calls. Trainings continued. They came early, they stayed late, and they were pulled off very important jobs and away from family to do it. So we had an eager group. So that was the first thing. There was a lot of content. As Dr. Gonzalez Marquez said, it was all in Ukraine with real-time translation. And so by the time they got the material, and they really obtained it quickly, even on the CBRN side and certainly on the trauma, pediatric, stop the bleed, we found that the sessions went much quicker. There wasn't need for translation. They knew what they were doing. So the content was developed all in Ukraine using several different sources. And John, I think you can talk more about the ATLS part. But with CBRN, there's really not a lot of dedicated material to it. There's a lot of different versions of it. We try to bring that together. And I will say our Ukrainian partners, when we were doing drills, would say, okay, that works in the US, that works in the UK, that works for FEMA, that worked in Syria, but this is a different ballgame. And you better change your drills and modify them to not just address nerve agents and chlorine gas, but white phosphorus. I'd never dealt with white phosphorus, but it was our Ukrainian colleagues that taught us that. So we're developing it. It's ongoing. As Catalina said, they are teaching now as we sit here. We did work ourselves out of a job, and the courses are now better than they ever were when we taught them. And we talk a lot about us teaching, exchanges, train the trainer, but what we haven't heard enough of, I think, and Jane and I were talking about this at the break, is what are the Ukrainians teaching us? Who is better right now in the world than dealing with trauma, right? Mass casualty, psychological trauma. When Ukraine gets through this, and she will, stronger and better than ever, I think we're going to be going to Ukraine to learn. Bordering countries all over the world are going to be going. So the content's important. Yes, you have to start with the basics, but you also have to trust your learners that they know what's best for themselves. And I can't say enough about the resilience of our partners. So CBRN's going well. It's a real threat. Unlike trauma, it's not probably as numerically significant. If it happened, it's a tragedy, but we also incorporated trauma and bombings, stop the bleed, to make it more practical. And again, based on our Ukrainian input. It wasn't us saying, this is what you got to do. They told us. And they did it very respectfully, very, very much respect back and forth, and we look forward to going back many, many times.
So thanks, Tim. I can speak to the ATLS component briefly. You know, we found that our Ukrainian colleagues had a real hunger to learn the highest standard of trauma care. You know, we can put together a trauma resuscitation course and call it the Harvard course, but that's not what they wanted. They wanted ATLS. And it was a real process to get that course implemented and disseminated in Ukraine. You know, the American College of Surgeons, they're great, but they have a lot of hesitancy to implement courses overseas in a context that where resources are limited, and frankly, there's not a proven track record of training people in ATLS. And you know, I think what we demonstrated with our training program is that it can be done, and it can be done to an incredibly high standard, and it can be done by Ukrainian instructors to a very high standard. And you know, after we showed, you know, how effective our program could be, the American College is now much more interested in using Ukraine as an example for trauma training programs in a resource-limited context all over the world. So I think it can really be a great example. It's still an ongoing process, and you know, there's a lot of roadblocks that we continue to overcome to get ATLS fully integrated and implemented. But you know, I think that we've shown that it can be effective.
Just to add quickly on what John said, I think reiterating what was said at the last panel, when things are out of your scope, it's still worth building that capacity. And when we started in 2022, ACS said no, and so we worked with them to adapt our own course and implement that. And we trained trainers and we mentored our colleagues. And so when we have progressed in conversations about promulgating and moving to that, everything is set and ready to go, so we're not starting at the base level. And I think we owe a lot to our participants in that adapted ATLS course because they really demonstrated that they were ready and willing to accept the standards by ACS. So we're in a much better place because of that.
Still lots of work to do, but the foundation is set.
And with the CBRN model, we came in with all our buzzers and bells and monitors and lights, and they said, look, we don't have those materials. We would like those materials, but we need to adapt to what we have. And it was not only the COVID pandemic, but the Russian-Ukrainian war, supply demand. We were carrying over a lot of supplies ourselves just to do these drills, but it became very apparent that you don't need all the disaster buzzers and bells and the latest things, because when you have a real disaster, those aren't going to work anyway. So because of our experience in Ukraine right now, FEMA's very interested in how we're doing disaster response, CBRN, trauma, mass casualty in low resource settings. Not just in conflict, in natural disasters, low resource countries. So again, the situation has trained us, and I think Ukraine is going to really take this on and be a leader in the world.
No, I agree. I think it's helpful having an organization that already works internationally, and I think because I was working with AHA, they already have an international, they just weren't in Ukraine, gave us a little bit of leeway to be able to work with them. Having support back home, so there has to be a facility that's willing to back us. And thankfully, we do have that one facility that's willing to back us, but then they see those small pilots that work, and then more and more people are willing to buy in and to do it. And I think to your point, Ukraine wants the best, and they deserve the best. So they're happy to have homemade trainings, but they do really want the best of the best, and they deserve it. And so being able to bring them what it is we also use as our own standard, it seems to be just huge for us, and I think is really just been a huge asset.
Great
Yeah.
point.
Thank you so much. And I think the world is changing, right? I don't like the word capacity building because I think there's capacity everywhere you go, but it's how do you strengthen that capacity, right? And I think that we're seeing so much more of that, and I agree with Tim and a lot of what was said on the panel. I think people are starting to use Ukraine as a model. You can do this. You will have the same standards, and you can promulgate it, and the response will be pretty incredible. Any questions from the room? They're ready to go home, probably.
It's been a long couple
Done
of
with the
days, but a
day.
great couple of days. It's been an honor to be a part of it.
I guess the other question that then I'll ask, because I did have a set of questions in case this happened, is now that you have like this trauma training, right, and that you have this AHA support, this ATLS support, what's the next step for Ukraine? How do we work with the Ministry of Health? How do we work with local partners to then go to that next step? And where do you think that next step will go?
Want to take it?
I think it's creating institutional partnerships, centers of excellence that can continue to collaborate with partners in the United States, and then there's different models. Hub and spoke or umbrella was brought up before, but I think once we have a center in Ukraine that is well established and partnered with the ACS, I'm hopeful that it will have legs and continue.
Yeah, I agree. Centers of excellence are key, with involving not only the university academic partners, and some of them are, yes, professors, but the hospitals, the people that are in the mix who are seeing not just civilian casualties, but military casualties. That is so key. And we've been working a long time with Ukraine, as I know you all have. Just when you get in step with the Minister of Health, you come back, there's a new Minister of Health. There's a lot of changing, but there is a young guard coming in who's highly qualified and very willing to work, and they want standardization. They don't want silos. So I agree with John that we need academia, we need institutions, we need hospitals, and then I think you'll get buy-in. But you have to get the ministers to buy in as well. And it's complicated. Some people want it the old way, but it's not going to survive the old way. They need to move ahead, and they are moving ahead, and they will survive.
I think too, oh, sorry. We've been talking a lot about multidisciplinary teams, including the nurses in that. We all know that the nurses are lack of education, opportunities. All of these doctor teams are going over there. How many of them are bringing nurses with them, right? If we set the expectation, we're bringing a doctor team, we're bringing a trauma team. Yes, Dr. Michelle, I know, and that made me so happy when I heard that, because that is the point. If they see, we can't just say multidisciplinary. If we come over there with nurses, you also had nurses come and speak just a month ago because they had already worked with Ukrainian nurses, right? So we can partner alongside, we can show them this is how we do this. We don't just put forward all the doctors and show you how to do things as far as doctors are concerned. We're showing you as far as the nurses as well. There's so many resources out there for specialties. There's nurse oncology specialties, right? There's pain nurses, there's rehabilitation nurses, all those things that I can be board certified in a lot of things in ER. There are also training things that I can help bring alongside that to help these nurses get to the point until standards rise there as well. Sorry.
Yeah.
Hey.
We're going in there like as teachers, and we're learning from the learners. And when we come in, and a lot of us are volunteers, we come in, come home, and back to our normal jobs. I don't want to be negative, but I think you have a Ukrainian hat on, but I always worry about a world hat.
Mm-hmm.
And heaven forbid we're going to have some other type of wars in the future. And obviously this war is different than any war prior. Are we documenting the changes so that we are really changing the protocols even here, or have that second protocol available if we're going to need it?
Yeah, we're doing our best. I've been involved, we all have, in a lot of projects where you go in, do your best, you mean well, you were there, and you really haven't evaluated it. Did you really make a difference? Did you make things worse? And this time we went in a war and evaluated it. Some of it was pre and post tests, some of it was learner retention, and then we documented it through publication. Not that papers change the world, but it does solidify it. And on every publication we put out as a group, there were Ukrainian co-authors. And it wasn't a lob, it was because they contributed. And I think that's a way of solidifying it, at least in the academic realm. But then you have to get them to be leaders in the hospital systems, in the government, and allow them to go. But you're right, it has to be solidified document, and it's not enough to say, I've been in Ukraine.
I want to just add, too, that we have a project, a virtual community of practice with Project ECHO and GMKA, and it's meant to build that camaraderie with practitioners from around Ukraine, but we have international practitioners join as well, and I think there's something to be said about the bi-directional learning, and a lot of the resourcefulness of what medical practitioners in Ukraine are doing is something that we can learn in the U.S. So it really started building an international network, not just across Ukraine.
Ukraine and that Eastern Europe, their culture's a little bit different. They were not leaders of the world like we were here, leaders of the world, let's say, in the medical field. And I'm concerned that we need to support them so they will become leaders and they feel comfortable and confident to say, hey, we got stuff to show. So I'm hoping, whenever you guys go there, you just support them to do that.
Certification's very important, and there was reference made, there needs to be learning and residency and training, yes, but there also needs to be certificate papers that are supported by a respected group, and that doesn't have to be from the US, it could be from the UK, it could be from Australia, it can be from Canada, but they do need their colleagues to realize that they're being trained or participating with established partners in the world. I do think that's very important, even as they're getting individualized in this whole process, which was our goal, work ourselves out of a job.
Work yourself out of a job.
Absolutely. Doctor, one of the physicians that goes over with my global regularly, most everybody in this room knows him, he pushes often that Ukraine is working towards getting their own version of American College of Trauma Surgeons, you know, so that they can create their own standards, so that they can then carry on their own torch of what their expectation is. So he would be able to speak to that far better than I can, but I know he speaks about that often.
That's a great point.
Any other questions? I want to be mindful of time, that we're over. And we're the last talk, so we want to let you get out of here. But just because we talked a lot about partnerships, we're happy to engage with you. Please feel free to reach out. Thank you, everybody.